This is Lauren coming at you to give you some facts about SBRT, about what are the contents of SBRT. You want to know what's it all about. Well, number one, we should talk about what is SBRT. What does the acronym stand for? It stands for Stereotactic Body Radiotherapy. And the stereotactic piece of the puzzle is talking about specifically the precise nature of it. So compared to conventional fractionated therapy, radiotherapy, the margins are much more tight. So say instead of a 5 millimeter margin, it might be a 2 millimeter margin, maybe a 3 millimeter margin. So the potential for a geographic miss is higher. So therefore it is also accompanied with much more imaging throughout, say, maybe the fraction. So doctor may instruct you to use image-guided, radiotherapy, not once, but maybe in the middle of treatment as well, or maybe one initially before treatment is initiated, and then maybe a second one to verify the positioning again, depending on, say, the physician's preference. But so risk of geographic miss is high because of the reduced margins. And the consequence of geographic miss for, say, the duration of one fraction, that is also a possibility why a physician may ask to interrupt the flow of normal treatment delivery and request, say another cone beam in the middle of the person's daily treatment. And so the reason why they may do this is because 1 day's worth of treatment is like a whole week worth of treatment for conventional radiotherapy. What do I mean by that? I mean, maybe a physician is treating a non-small cell lung cancer to 50 gray for 5 days. So that's 1,000 centigray per fraction. Compared to standard fractionation, which utilizes in the same non-small cell lung cancer example, it may utilize 7,000 total dose centigray fractionated over 35 days, giving us 200 centigray per fraction. So as you can see in this example, a person is getting 5 days worth of treatment, of conventional treatment, condensed into 1 day using SBRT. So the consequence of missing 1 day, if you were off by just a little bit, contributes 20%. So that's essentially like being off whatever degree at which you were off 20% of the time. That has significant consequence to possible recurrence or hitting a critical organ of say the heart or the spine. A lot of times, due to this high consequential nature of SBRT, the therapist is not alone in delivering. Many times, and I think it's by nature of what we're doing. I can't imagine being another way. But the physician needs to be present during, the decision to accept the imaging. So accept after the cone beam, say, has been acquired, alignment will occur. The physician accepts the current alignment in the way it is, and then delivery is initiated by the therapist. And physician and physics needs to be present, at least in my experience. And I'd be surprised if that's not true universally. What else what is worth mentioning about SBRT? Why do SBRT, right? Why not just give everyone a standard 35 fractions to a non-small cell lung cancer? Why not give them SBRT? Why not be able to provide somebody with a relatively low burden but equivalent cure? How cool is that? Imagine also someone traveling maybe far away to come to your clinic, and maybe the burden of staying in a hotel is relatively high over 7 weeks, but they can reasonably afford to stay 1 week. That'd be a great selling point. Plus, it gives you an opportunity to help this person who might otherwise go without your help had they not had this option presented to them. Also, what other burdens might impact this decision? It could be, I don't know if cost would ever enter in. I don't know if there's a difference in cost. but it's usually convenience, maybe age, and the burden of coming to these daily treatments is high because of mobility issues, pain issues, comorbidity issues. And you think about it, you can help as a facility, you can help way more people if you are able to deliver relatively equivalent dose of therapy as far as compared to standard fractionation, and give the same impact, give the same benefit, but be able to do it in a faster way, in a more condensed way. Essentially, they're done with their treatment in a week. That enables the next person to enter their spot and be completed in a week. And the next person, instead of that one spot being occupied for 35 days, now they've essentially have 6 other patients that they can serve compared to, say, the conventional fractionation where one patient would occupy a spot on the schedule for 7 weeks. Imagine being able to help 6 times the number of people because are able to give an equivalent effective dose, therapeutic dose, to kill their lung cancer in a way that's abbreviated. Yeah, the stakes are higher, but we're here to help people and we're up to the task as radiation therapists. So I hope this was helpful. Drop some questions in the comments below and we'll see what other people can answer for you if I've missed something.